15 minutes of the program. A good way to kind of finish it up, too, in terms of where we're at. Well, actually, about 18 minutes. So I want to thank you all for staying through to this last part. I think this perhaps could be one of the most exciting components, simply because of the fact that we have new drugs in a category that's never had anything for it, and that's the area of geographic atrophy. And I think we had a wonderful presentation right before it that put it all in perspective. So let me start at the end with Mo and have us each individual describe what they do in Retina. I think you're going to find it is fascinating what level of Retina practice some optometrists are at and what they do. So Mo, I'll start with you.
Just to describe what I'm doing.
Where you're at and what you do.
Well, for the last 27 years, I've been practicing at the Charles Retina Institute as a Retina OD. That's a new term. All I do is Retina all day long. So no refractions, no primary care, just Retina. And as I'm sitting here, I feel like I'm developing geographic atrophy by these lights shining in my face. Because that's what RPE does, constantly dealing with toxic effects of light and other things in life. But yeah, I'm basically a Retina OD, just like Mary Beth.
Yes. I'm Mary Beth Yaki. I work at the Cincinnati Eye Institute. Somebody at break asked me how many doctors are in my practice. There's 84 of us total, 26 optometrists with lots of subspecialties, but I'm like Mo, 7 years younger than him apparently. I've been at CEI now in the Retina group as a Retina OD for 20 years.
Chris.
Yeah, I'm clearly the outlier on the panel. But first, thanks for having us here. It's great to be here. Chris Sims, I lead the commercial team at Iveric Bio. I am not a optometrist or a retina specialist. However, I think I estimate I spent about a third of my life around retina specialists or optometrists, so I could fake one well enough most of the time. So.
It is fascinating. So my first love actually was Retina. I did my residency at a VA that was almost all Retina, and I got an opportunity to do a fellowship under Dan Dury, a top cornea guy, and that changed paths for a while. But I loved it so much that I actually went back and did a preceptorship for over 2 years at Retina Associates of Kentucky, where I was there a day and a half every week for well over 2 years, and then joined the practice on a day. And then, so this has been an area that's been fascination for me, and one that I think is amazing, but not to the level of the two over here that have dedicated their life to that area. So how significant is, and I'll start with the clinicians, Mary Beth, how significant is an FDA approval for treatment for geographic atrophy?
I think more than we will ever realize. For so many years, I feel like geographic atrophy has been looked at and dismissed. And there are patients who know they have loss of vision, yet we don't understand how to classify that loss of vision because it's not on the VA chart. So this new treatment is filled with hope for those people who have been suffering with unexplained vision loss, lack of, they feel like they have people they can lean on or lean into. So if nothing more, it gives us hope to bridge to the next and better treatments, because there's a lot coming down the pipeline that are just getting started. But this is very exciting.
Makes sense. I agree. I think it is incredible. I'm going to ask a little bit too, and then I'll hit Mo on this next one. But Chris, you saw the numbers, as you already know, the 1.5 million people with GA. Actually, they say between the year 2030, and it's quite a range because it depends on how long people live. Between 2030 and 2050, we could have as many as 20 million people with AMD, which would assume somewhere around 3 to 4 million having geographic atrophy. Those are not small numbers. It's pretty incredible numbers based on the definitions. Where does the company think those patients exist? And then I'd love to get Mo's opinion too, based on working with a lot of other colleagues, and then Mary Beth, as far as where those patients are. I know I see a fair number, but where are they residing? Where does the company think they are?
Yeah, it's a great question. So a couple of maybe additional numbers to give that the numbers you quoted a little more context. First of all, that 1.5 to 1.6 million number that's often quoted, we quoted as well. The truth of the matter is the data that we pull that is fairly dated. In fact, some of those epidemiology studies goes back 7 or 8 years. So just based upon that alone, you would expect that numbers potentially very understated. We think our best modeling would suggest that a quarter to a third of those patients have at some point been diagnosed. Some of them have been referred to a retina specialist. Typically the ones that have been referred to a retina specialist probably have more advanced disease, which would make good sense. But you put all that stuff together and you quickly realize that the vast majority of these patients are not sitting under the care of a retina specialist or haven't been referred to a retina specialist. So they're sitting with folks in this audience, with the optometry community by and large. And as we've modeled some of that stuff out, I think some of the data that we can gather would prove that to be true. We think as well that the there is a potential underdiagnosis, right, issue within this disease. When you don't have a therapeutic to offer these patients, and you may have a disease that you think is slow progressing, although it's probably faster progressing than many people think, we believe there's a potential for underdiagnosis. So a huge opportunity. I think that's one of the reasons why we're actively engaging with the optometry community to help with that education.
Yeah, you've done a great job. It's been terrific. Well,
So according to the US Census Bureau from years ago, if you think about every day in this country, 10,000 people become 75 years old until 2030. I mean, that's staggering. So macular degeneration, geographic atrophy, these are not things like Oguchi's syndrome, where an OD may have a chance of, in 15 years, maybe see a patient. These are patients that are roaming in everyday practices. Not only that, we're now dealing with people who are in their 50s and 60s, whose parents are in their 70s and 80s, who lost vision from macular degeneration. So these 50 and 60-year-olds are wondering, what's going to happen to me? What's going to happen to my children? So this, you're right. I mean, AMD as a whole, that was a study in 2017 that showed how rampant misdiagnosis and lack of diagnosis exists, not just for AMD, for intermediate AMD patients who are at risk for geographic atrophy and neovascular AMD. So we have to do a better job capturing these patients, educating these patients, because they're in everyday practice.
I agree.
If you see adults, we have them in your practice.
Mary Beth.
And I will echo that GA is not usually in the retina physician's chair unless there is a wet AMD eye, because there is nothing they can treat. And I would say that I have conversations that my patients sometimes hear in the hallway. I work with 11 retina specialists. I'm the only OD in that group. And so I'm the only female in that group too. So there are some, like my parents used to have these loud conversations in the hallway where I'm trying to explain to some of the retina MDs the impact of GA, because it hasn't been in their chairs. They don't see a visual acuity measure. And so trying to explain to them the importance of this treatment, not all of them, some of them, the patients will ask, were you arguing out there? And I'm like, it's the only time we have to talk and we've got a discussion. But yeah, I mean, it is in primary care optometrist offices.
I think you're right. The interesting thing on education as we come out this year with this is that first you have a desperate population where there's never been anything for them. Some great cases of how fast it progresses in some examples. But at the same time, the early data, and perhaps long-term data, we see some level of halting. But the early data and what we're going to come out with from the FDA is really a slowing of progression. Chris, I'll start with you. How does a company balance not overextending what this is, because the patients want something, the doctors, optometrists want something for their patients that can finally do anything, but yet we really only come out talking about slowing progression of the disease. So it has to be some balance. How do you do that?
Well, I think you do it first in partnership with folks in the community, right? You're right, there's a heterogeneity of this disease that may be different than what you would see in like a wet AMD patient population for sure. But I think at the end of the day, it comes down to having that education and having those conversations with, and truthfully, the entire spectrum of the eye care provider community, with optometry through to the retina specialists as well. And on many of those things, as you all know probably better than I do, it comes down to that conversation you have with that patient and what's important to them and where they are in their disease and what type of treatment they're up for. My personal hypothesis is that balance and patient selection we'll see with time will move to patients that actually have earlier stage disease. Again, the data will ultimately tell the story, but I would suspect that this is a classic disease where earlier intervention, diagnosis, detection, and therefore treatment is, I believe, most likely to lead to better longer-term outcomes, which in this disease is defined by the preservation of vision.
I believe so too. I think there are probably some devitalized cells there, but there's probably some that would go to that. But with perhaps this inhibition of the complement system, perhaps we keep them from ever getting to that point. And that's the great hope here. Mo, you and Mary Beth both said, there's so many of these patients, we have to start identifying them well. How does an optometrist in private practice, you obviously have a lot of tools. And to be fair, most optometrists have OCTs, especially those that are referring patients in, wide field, et cetera. What are they supposed to be looking for today in light of these drugs that are eminently going to be available for their patients?
Look closer. OCT exists in most optometrist practices, but OCT, which is a tomography unit, is used mostly as a topography unit. So in this type of disease, you have to look at morphology. You have to get used to looking at cross sections, not just one in the middle, like horizontal and vertical. Go through your rasters, look for telltale signs of not only existence of GA, but the pre-GA lesion. So we have to have some education about that. That's going to take a while for folks to get mindset of looking at matrix and looking at analytics and looking at actual disease state. Go to your high resolution OCT scans, do more rasters, look and try to capture, And then I want to add something to the issue of patient expectation. Imagine you have a patient who's 75 years old with a small GA, and we see these patients, the OCT unit that we use has a good NIR, and you can look at the NIR and go serial image. You can see within 2 years or so, this disease so rapidly progresses that you have to have that conversation with the patient. As a 75-year-old who's got a chance to live to their 90s, do you want to lose vision in 2 years? Or if you could delay this for you to eventually lose vision in 8 or 9 years? I mean, it's very intuitive, I think.
Says a lot. Mary Beth, what are you going to be teaching your co-managing colleagues who will be sending patients to you and your 9 retina specialists?
11.
11?
11
Yeah,
plus
11, 13 total, yeah.
Just for, I think, listening to the patient. If you have no tools, listen to them and listen for the symptoms of missing letters when they're reading, and listen to what they're saying about metamorphopsia and those things that you just have to listen to the patient, look at them. Then look in their eye, and obviously, if you have a good view, great. And then if you're lucky enough to have an OCT, like Mo said, OCT is amazing. But my very favorite tool, if you're lucky enough to have it, is a fluorescein autofluorescence, because FAF. If you have an Optos machine, you might be able to get an autofluorescence. That will tell the story to the patient easier than anything. If you have an autofluorescence from years prior and compare it to today, they're going to want treatment. And they'll see the growth and they'll feel the growth too. So it helps. It acts as a really great tool if you're lucky enough.
I like the snap.
Yeah, that's great. Can I add a couple of thoughts to that? So I wholeheartedly agree. I think we've heard from a lot of patients as we do research and get prepared for hopeful approval and launch. Some of the patient experience when it comes to their vision, they could still be reading 20/20 on a regular eye exam, but they may talk about other visual dysfunction that may be bothering them, and that potentially could be a sign around other things, again, potentially GA. The only other thing I would add is, we say look for it. I think you're spot on. If you're not looking for it, you may not see it. But after you see it, I would add the extra step of code for it as well. And then, today we sit here, there is an approved product that was just recently approved by Apellis, and we congratulate them on having the first GA product on the market for these patients. And depending upon your situation, today you have the option as well to refer after you do that coding.
That's great insight. Did the clinical trials reveal who is perhaps a non-candidate or who are the ideal candidates? And I do agree with that early diagnosis, of course, being critical. But what came out of the clinical trials, Chris, that may help us as optometrists identify those very best patients to lead off with?
Yeah, so, I think what we saw in our clinical trial data is that, and we had a proportion of patients that had, disease that was, juxtafoveal or extrafoveal, and there seems to be a higher level of complement activation in earlier stages of disease. So again, this disease starts often on the periphery and starts to progress towards the foveal center point. So I think patients that have maybe peripheral disease may be ideal in terms of the potential to inhibit and slow down earlier. But I think we'll learn a lot in the next few months when we talk to your colleagues in the retina community. For example, the patients that they'll likely start these therapies on are the patients in their chair, and often those patients that may have more advanced disease. In fact, many of them may have disease already, may have lost vision in one eye, but they still have an healthy eye, but it has some form of early GA, and we think that's probably like an early bolus of patients to get treated. Sadly, this disease also has a pretty high rate of bilaterality. I know in our clinical trials, I think 80% of our patients had bilateral disease, and we modeled out in just the broader population about a 50% bilaterality rate. So this is not just 1.5 potentially plus million patients in the US. This could be 2.5 plus eyes.
Yeah, and say 5 million by 2030 to 2040. If you look at some of those estimates, that's really big numbers. So one thing we talked about, we have about 3 minutes, but one thing we talked about extensively was how you have this almost continuum of disease state. Like today, I love this last presentation because we had everything from, Pixium for the very end stage, you had adaptive, when you're dealing with the patients to have the ability to see, gaining multiple lines with their augmented reality glasses, which is fascinating. You've obviously got AREDS formulations, and prior to that, just some sort of nutritional. You've now got GA treatments that fit into there. How do you guys look at, Mo and Mary Beth, how do you guys look at the continue? Could you see a day when optometry perhaps is building, like they're building dry eye clinics a lot now, building an AMD portion of their practice with all that we have?
Oh yeah, eventually they're going to be not only multi, type of, the routing of the topical medications, the oral medications, but it's also a multifactorial condition. And if it's addressed from different factors, the OD can co-manage the patients that they might not be able to get the injection in the offices, but they can have the adjunct treatments per se. And regardless of the condition, when ODs refer patients to retina specialists or any specialty, they need to keep a tap on their own patients. They need to follow their own patients. So in co-management sort of model, there should always be that control from the referring OD.
Good point. That's what makes like Ocuterra and Ocufire so exciting, that we may have some, for diabetic retinopathy, some early treatments to start out when you're first seeing a dot and blot heme. But then when you are to the point where all 4 quadrants are involved or IRMAs are picked up, that you're finally saying, okay, now I know when to send the patient off. We don't have anything for those gaps. And the same thing here maybe in retinal disease. Mary Beth, your thoughts?
When I, again, speak to my colleagues about this and the retina group, basically, they'll say it's like, think about what we were like with Visudyne, and how we had such a continuum of now treatments for wet AMD. We're just at the starting point for dry AMD. We're just starting. So this is it has to get better. It has to be something other than an injection. Otherwise, retina specialists are never going to be in the operating room. They're just going to be injecting all day. So they don't, and I believe they truly want other options for their patients as well. So yeah, I think optometry definitely is going to be involved further and further as time goes on.
That's great. Final comments, Chris? So we'll give you the table to kind of wrap it up. We're right at that end point. Any final things you want to add in, and then we'll conclude.
Thank you. I would just start or end where I started, which is thanks for the opportunity to be here. It's an exciting time. I think the unmet patient need is pretty obvious. And as we sit here today, we're 171 days, not that I'm counting, I am counting, from our August 19th PDUFA. So hopefully in 172 days, you and your colleagues and the folks in the retina community will have a couple of options for these patients that have this big need.
Wonderful. Exciting to see what we can do in this area. It can expand the entire area, as was mentioned, so many of the technologies that were presented. So with that, I certainly want to thank our experts and Chris, a great person and executive who's obviously showing that a partnership towards where we're going to go in the future. But Mo, Mary Beth, Chris, thank you so much for your great insights. And thank all of you and the OAS organizers for your time today, for being part of such a great program. Craig, you want to finish off, or can I just thank you and dismiss? All right. Thank you, Chris, and your team. Thank you all. Have a great rest of the secret program.